Okay, it's about 2 minutes after the hour, so we're going to go ahead and get started. Hi, everyone. I am Pivot's Engagement Officer, Amy Donahue, and I am here to welcome you to the 9th edition of our virtual panel series, Voices from the Field. We are so happy to have you on the line for today's session. This is the second in a sort of sub-series of 3 special sessions dedicated to discussing our ongoing clinical activities at each level of care in Ifanadiana District. So last week we talked about our community health program. This week, we'll be focusing on our primary care activities at the health center level, and next week, we'll cover our activities at the district hospital. So when I share the recording of this session with you later today, I will also provide a link to the recording of last week's in case you missed it. It was a good one, as well as the link to the registration page for next week's session, where we'll hope to see you on the line. So just a few super quick things I'd like to note before I hand it over to our panelists. First, you may have noticed that we have a different moderator today. Dr. Alicia Mayfield, our Chief Medical Officer, will be guiding today's discussion on primary care, while our Executive Director, Tara Lloyd, who's been leading these calls, takes a much needed break with her family, truly leading by example and encouraging us all to maintain a healthy work-life balance, especially during these times. So Tara will be back with us next week, but in the meantime, we're super thrilled and grateful to have Alicia step in her place. Secondly, as I mentioned, we are recording this session, but you can rest assured that while you can see and hear us, we cannot see or hear you. However, once we enter the Q&A portion of today's call, about halfway through, we would love to give you the opportunity to use your own voices to pose your questions directly to our panelists. So if we get to your question and Alicia says your name, I'll enable your mic capabilities, and if you feel comfortable, we would invite you to unmute yourself and present your question. This has been a really nice way for us to feel connected to you all over the past 10 weeks, and we hope you feel the same way. But if you can't or would rather not for any reason, feel free to ignore us, and we will proceed after a few seconds by asking the question on your behalf. And lastly, if you haven't yet had the chance to submit your questions for today's panelists, please do so at any point during the call. Just use the chat box down at the bottom of your Zoom application to message us with your question. And the sooner in the call that you're able to submit, the better, just so we can get to as many of them as possible. And with that, I will hand it off to Alicia.
Thanks, Amy, and welcome again to everyone. Thank you for joining us for this next conversation, Voices from the Field, with our team here at Pivot. We really appreciate your ongoing participation. Many of you have been coming back week after week, so that's wonderful, and we love having new faces as well. I'm going to start with just a few things that Tara likes to point out at the beginning of each call, which is one, a couple acronyms that might be used. So CSB is Centre de Santé de Base, which means basic health center. So you might hear that referenced. Probably won't hear today CHRD, but just in case, that's the hospital. And we often will use the terms Ifanadiana and Ratsimbazafy somewhat synonymously. Ifanadiana is the district in which we work, and there's also a primary town in the area of Ifanadiana, and then Ratsimbazafy is the town where Pivot's office and many of our staff are based. So with that, I'll also give you a little bit of an update on the situation with COVID-19 currently in Madagascar. As of now, there are 612 diagnosed cases, 10 of whom are critically ill. In the last week or so, they've had the first 2 deaths happen in Madagascar from COVID that we're aware of. They've now tested almost 10,000 people for COVID, so the numbers of tests are ramping up, which is quite encouraging. As the number of tests have gone up, of course, we're diagnosing more cases. So the rate of case increase has gone from about 0 to 3 new cases per day to now somewhere between 15 to 45 new cases per day that we're aware of. There are still no cases that we know of in Ifanadiana District, which is encouraging. There are more cases kind of in the general surrounding area, including 9 in Fianarantsoa, which is a nearby town, and 16 in the kind of region that we're in. So it does seem like a matter of time before we have known cases also in Ifanadiana District. But as we're preparing for COVID, we also really want to work with the government with an ongoing focus on achieving universal health care, and also making sure that all of the regular services in the district are strong and continue to function whether or not there's cases of COVID and whether or not those cases increase. It's really important to make sure that women are able to deliver in healthcare facilities, that children who have malaria are diagnosed and treated for that, and that all of the other normal illnesses that are happening all the time are diagnosed and treated appropriately. So because of that, we wanted to do this series of 3 conversations looking at the 3 different levels of care in the district. So last week we talked about community health and got some great perspectives about what's happening in the community in Ifanadiana District and how we can support that on an ongoing basis. And then now we're going to talk about primary care. And for those of you who might not be familiar with the term primary care, it's just basically if you go to a doctor and you go to a regular clinic and you see your doctor, you walk in, you get some tests, you have a conversation, you walk out, that's primary care. And then secondary care is hospital level care. So that's what we're going to focus on next week with some of our doctors from the hospitals. So with that, I want to turn it over to our fantastic speakers today. We're going to start first with Dr. Lara Hall. She is a family medicine physician. She was Pivot's medical director from 2015 to 2017 and helped establish many of Pivot's programs at the primary care level as well as other levels, including working with the Ministry of Public Health and our team on developing programs for children under 5 and malnutrition. She's currently working at Cambridge Health Alliance in Boston and seeing a lot of COVID-19 patients herself, but she's going to give us a historical perspective of kind of why we chose to focus on some of those programs early on at Pivot and what it was like helping the team and the government to develop those programs further. So Laura, please go ahead.
Thanks, Alicia. Hi, everyone. It's great to be here today. So when I first started working as the medical director of Pivot in January of 2015, the road for the work and the scope of what we wanted to be doing still wasn't clear. And we knew that there were many aspects of the public health system in Madagascar and in the district that weren't working well, and we knew that there were many challenges. And we knew that we wanted to support the entire public health structure in the district, but really needed a plan of how and where to start. And one of the key early pieces of data that we used was around childhood mortality and malnutrition. And childhood malnutrition is a leading cause of disability and death worldwide, but it's particularly severe in Madagascar. About close to 50% of children under 5 are stunted, which is a way of describing chronic malnutrition, and about 8 to 10% are wasted, which is a way of describing acute malnutrition. And Pivot had done a district-wide household survey in 2014 that showed that chronic and acute malnutrition were very high, but similar to the national averages. But it also showed that childhood mortality was twice as high in the district of Ifanadiana compared with Madagascar as a whole, about 145 per 1,000 live births. And there had been some official government plans for public health action and implementation of malnutrition programs and treatment as early as 2004 in Madagascar, but there have been a lot of barriers, political instability, resource limitations, fragmentation, and so it really had limited the progress of the programs. And so this felt really important for the health of the district and for the health of the individual people living in the district. Childhood malnutrition has many consequences. It makes children more likely to get sick and die from other illnesses like diarrhea and malaria and pneumonia, but it also affects brain development and school performance. And so the more we looked at the data and the health of the people in the district, the more it became clear that this was really the area that we should focus on, fighting malnutrition and mortality in children under 5. And so we worked with the local health officials and we wrote an official request to the Ministry of Public Health asking if we could help support these programs. And they agreed, and so in 2015 we started working on the programs. And so in addition to starting to work on evaluating and screening for and treating malnutrition, we also partnered with the Ministry of Public Health in the district to expand and improve a protocol or a guideline called IMCI. And this was something that was started by the the World Health Organization. It stands for Integrated Management of Childhood Illness. And it's basically a protocol to help community health and healthcare workers to diagnose and treat some of the most common causes of illness and death in children. Diarrheal illness and the dehydration that can result from that, malaria, pneumonia, and malnutrition. And as we started to work with the ministry on acute malnutrition and under 5 care, it was clear right away that we really need to provide support in all areas of the health system. And there wasn't really any one aspect of the health system that was functioning well. And so we couldn't just work on screening for malnutrition if there wasn't going to be the capacity to treat it. We couldn't work on diagnosing pneumonia or malaria in children under 5 years old if the community health workers and the health centers didn't have the antibiotics or the medications to treat pneumonia or malaria. And so focusing on malnutrition and under 5 care really allowed Pivot to get a foot in the door to work on all aspects of strengthening the healthcare system and primary care with the Ministry of Public Health in the district. And so, for example, as part of the malnutrition and the care for children under 5, we worked on improving the infrastructure of the health centers, the hospital, and some of the community health outposts, including water and sanitation at the health center and the hospital level. We helped support the government to train healthcare workers, helped the ministry to pay salaries and hire more healthcare workers to improve primary care. We worked on helping to strengthen the supply chain management system so that nutritional supplementation and medications were more available, but also free for patients. And we also worked with the government to strengthen social support and social protection for patients. And strengthening these aspects of care around malnutrition and under 5 care didn't just improve the health care of children, but it also improved health care for the whole district and utilization overall. And the other piece I think that was really important is that working on starting these programs first at the health center level really allowed us to help work with the government to strengthen care at all 3 levels of the system, at the community, at the hospital level. It was clear that we wouldn't just be able to treat malnutrition and under 5 care at the health center, that it was also really important to work in the community and at the hospital. So I think by starting with these 2 areas, it allowed Pivot to work with the government to really improve primary care as a whole, care at all levels, and for more than only children under 5. So I think I'll stop there and turn it back over to Alicia and Lova, and happy to answer questions later. Thanks.
Great, thanks so much, Laura. And one point we might pick up on later, if people are curious, is the social support piece, because I think that's something that people don't often associate with primary care, and it really is a key component of supporting people's health. But let's move on now to Dr. Lova. So Dr. Lova Ratsimbazafy, I don't know if I'm pronouncing it right, sorry Lova, but she is a generalist physician. She did her training in Antananarivo and joined Pivot back in 2016. She worked her way up to be the health center manager after a period of time, and then as of last year was further promoted based on her dedication and leadership to the new position of Deputy Director of Primary Care. So she is really expertly placed to lead us in this discussion today about primary care services and how important they are. So Lova, please take it away.
Thank you, Alicia. Hi, everyone. I'm glad to be with you today. So to begin, I would like to walk you through the CSP of Ranmafana. So as you can see, we are at the entrance of the health center, which is situated at the center of town.
Ils peuvent voir la vidéo, donc t'inquiète pas pour les délais.
Okay. So in this case, it is accessible by road. With this video, you will be able to better understand where we work and the rehabilitation that have done.
Yeah, sorry, we're seeing the video with a little bit of a delay, so we're unsure where you're at. Okay.
So here we are at the pre-triage area. So that has been set up especially for COVID-19. Here, where a nurse takes the temperature and understands status around COVID with suspect or confirmed cases. And the health center is divided in two own area for preventive care and especially for sensitization, vaccination, antenatal care, and family planning. And the other is for the curative area, especially for the outpatient visit. Here is the room where we screen for malnutrition and see children under 5.
Okay, we're having a bit of a technical issue. Amy, we can't see the video anymore. Okay, here we go.
Okay, so for the curative area, it's especially for outpatient visit with an inpatient capacity of general observation if necessary, delivery, and basic emergency services. And there are specific services implemented with pivot, malnutrition, and tuberculosis. The most frequent health issue we see at the health center are for adults. We treat malaria, especially recently. We have been in the malaria season from November to April. Also, there are respiratory disease and non-communicable disease such as hypertension and epilepsy. For the children under 5, we most often treat the big 3: malaria, upper respiratory infection, and diarrhea. In order to strengthen primary care, Pivot is implementing a holistic and integrated approach to health system strengthening. We are not only improve quality of care, but also increase health facility readiness and reducing social and financial barriers to care. So far, we have been working in 6 health centers, and now we plan to expand to all the 15 health centers in the district by the end of the year. So I won't be able to introduce everything we do, but because I will need more than 10 minutes, but I will explain a few. We are, so for the resource and capacity building, we are ensuring that there are enough medical and non-medical personnel in the health facilities. This is really one of the pillars of our work and one of our first project at the health center level. When Pivot started, a number of health facilities were closed or had only one paramedics We organize training and for the health practitioner of a variety of things and focused on accompaniment and routine capacity building. This year, the main training will be on updating of malnutrition protocol, good practice, and management of vaccination and family planning. Last year, I focused on increasing basic diagnostic capacity at the health center in order to facilitate primary care and increasing quality of care. More especially, we now have basic and rapid diagnostic tests such as pregnancy tests to determine hemoglobin and glucose level, as well as urine type test. On last point, I would like to highlight is our unique approach to primary care by actively integrating social and community services, especially for family of children suffering from malnutrition, tuberculosis patients, and pregnant women. This truly help us improve outcome and expand our primary care approach beyond readiness and quality. So it's a few about our primary care. Thank you.
Thanks so much, Lova. That was wonderful. And in the video, you got to see a few glimpses of some of the infection prevention and control measures that the team has put in place even before having any known cases of COVID in the district. So you saw that kind of pre-screening area where the nurse was wearing a mask and was using a no-touch thermometer and asking some screening questions. And then you saw, I don't know if you could tell this, but the patients were spaced out. Different groups of patients were spaced out by 6 feet. So you might have a mom and her kids together, but then the next mother and kids would be separated by a distance of 2 meters. And Lova can certainly talk more about some of the other measures that are being put in place for COVID. But now I would like to turn to Laura Cordier. She can talk more about some of those things Lova was mentioning about reinforcing human resource capacity, training, increasing numbers of staff, etc. And I think everybody probably knows Laura by now, but just in case, I'll say a couple quick things about her. So she studied the control of infectious disease at the London School of Hygiene and Tropical Medicine. So she's a perfect background to now be with us in this current scenario. She has been a key team member of Pivot for the last 6 years since Pivot's inception, previously as the Director of Monitoring and Evaluation, and now currently we're all very excited that for the last year she has been Pivot's National Director. So Laura, please take it away.
Great, thank you so much. So I, first of all, wanted to thank Lara and Lova. This is great. I now want to talk a little bit more about where we're taking primary care and our program. So you got to see the CSB of Renomafana, which is glorious and beautiful. But I feel like it's not showing you exactly the situation right now. Renomafana has gone through an iteration of improvements over the last 6 years. And I'm going to share my screen really quickly to give you an example of 2 health facilities that we're going to be going to by the end of the year. So give me just 1 minute. Perfect. Here we go. This should be working. Can you see my screen? Yep.
Yes,
okay.
we can.
Okay, I'm going to put myself in Great. So this is the CSB of Mpasinambu, which is in the very north of the district. It is the furthest health facility from the center of the district. And it takes 4 days to get to give you an idea. So really, really quickly, this is what the health center looks like. This is the external consultation room. This is unfortunately a very basic but normal scene, the delivery room. So just put yourself in the headspace of a woman having to come very far away from a health facility to deliver in this space. And then this is the hospitalization room. So we're going to be fully renovating this health facility this year, which we're really excited about. And then this is the CSB of Andrangavula. Very basic structure, but actually a key health center because it acts, believe it or not, as a referral center for satellite health facilities. And so more than ever, it needs to be ready, but it isn't in its best shape. So this is the room for medicine, so very little stock. This is actually the external consultation room that has some space for delivery right up there in the corner, and an example of hospitalization and observation. So, you know, there's still a lot to be done in the district of Ifanadiana, and we're at a point where Pivot is really shifting its approach. Most recently, we've done a deep dive in health facilities, and the CSB of Rwanda is a perfect example of that. And right now, we are working with the Ministry of Health in implementing what we call UHC, which is Universal Health Coverage. And it's going to be a collaboration, and it's going to allow us to expand and really go actually increase primary care at all health facilities at once, which is going to be a huge challenge for us. But we're going to be, as Lova mentioned, working on human resources, making sure we're meeting norms, infrastructure, much needed, distribution of equipment, new maternities, all up to international norms, basic equipment for diagnosis, for primary care and external consultation. So it is really, really exciting for us. And the vision is aligning with the government's vision of UHC. So it's equitable access to care, increased quality of care, but also reduced financial shock. And so we briefly talked about it, but one of the key components here is the fact that we're reducing financial barriers. Now, previously, we've done a reimbursement program. We're aligning with the government to be more aligned with their approach of setting up what they call a national KES, a fund for solidarity for health. And we're going to help make that functional. And it's just going to shift our approach. UHC more than ever is important. Primary care is important. In the space of a pandemic and an epidemic in Madagascar, we've always felt, whether that it's for plague, whether that it's measles, primary care is what makes it work. It's what makes it allows links within the community. And as COVID is approaching day by day, truthfully, the health center is what we're focusing on. We want to make sure that people have a place to go to seek basic care, start contact tracing. And so I will hand over. I realize we're at the 30 minutes. So much more to be said, but we'll start interacting. Alicia, I'll hand it back to you.
Great, thanks, Laura. And I wanted to point out, I actually used the wrong term earlier. I said universal health care. The correct term is universal health coverage, as Laura said, but I think we really like to think about it in terms of care. Many governments around the world are looking at UHC purely as a financing mechanism. How do you fund an insurance program for health so that everyone has a national insurance card, for example? The problem with just setting up an insurance program is that you can have health insurance for everyone, but if you have crumbling buildings like the ones that Laura just showed us, and you have 2 nurses working in a healthcare facility that's seeing 20,000 people, obviously you can't really provide care. And so what we're really doing is working with the government on how do you infuse that care aspect that is so key, while at the same time working on the coverage so that everyone has access to care, but it's also high quality care. So I want to open it up now to everyone for questions. We have a couple questions that were submitted in advance, so we'll turn to those first. But please, I want to encourage all of you who are joining us today, don't be shy, send questions our way. If you don't want to actually say your question yourself, just let Amy know and we'll read it out for you. But the first question comes from Norma Andreadis. Norma, do you want to say your question? And I think I'm going to direct this to Lova.
We actually don't have Norma on the line, but I can go ahead and read it if you'd like to start there. Okay, so this question is, what are your most common patient issues? What are your biggest impediments to providing care?
Okay, so I have already mentioned the most frequent disease, but I will talk about the challenges and the impediment to providing care. So the first of all is late referrals. This is particularly challenging for health centers that are far from the road. We are trying to reduce financial barrier, but when there is an emergency, geographical barriers are very difficult to overcome. And we need to continue to work on early diagnosis and basic emergency services. Then we have basic equipment. We are trying our best to provide care, but with basic equipment in health facilities. After that, health seek behavior and trust. That is both in the hands of the patient and our as well. We need to continue working on humanist care and building the trust of the community. So finally, our challenges is the coverage. Our data show, as presented last week, that even though we are increasing utilization of care, we are not reaching the farthest away. So proactive community health is the key for that.
Yeah.
Thank you.
I will add just on a point that Lova made about trust and humanized care. This is coming up a lot in our qualitative and operational research. You know, actually what we're finding is you can have the prettiest health facility like the CSB of Renomafana, but women will not come if they are not confiance. I can't speak English today, it's the worst. If they don't trust the midwife, if they don't feel that they're being accompanied, and the role of traditional midwives is still very powerful here in the community that we serve, and they have a role to play as well in establishing that trust. So I'm sure, Alicia, you have a few things to add as well.
Well, I think that trust component is key, and I think it's going to become more key in the months ahead. Whenever you have an epidemic of an infectious disease, that causes a lot of fear. It causes a certain amount of anger in the community and fear for healthcare workers for their own safety. So I think the fact that Pivot has these deep roots in the community and is known and trusted is going to be invaluable in the months ahead as we try and work together with the community and with the government to address the changing needs. And maybe I'll turn it over to Laura Hall as well and see if she has anything she wants to add on this question.
Sure. Yeah, I would say in addition to what Lova and Laura and Alicia said, you know, I think one of the challenges that existed when I was there, and I think it still remains a challenge, is just that there isn't any one part of the whole public health system that's working well. And so as you get into more primary care, there are many different aspects that it feels like we need to work with the government to support. And so, you know, I think universal health coverage or care is a really important piece of that. If you're only doing training for health workers, healthcare workers, but they're not feeling motivated to come to work, or they're charging patients, you know, fee for service, or you know, otherwise that there are barriers to care, then that's a challenge. I think, you know, one of the things I mentioned was supply chain, and I think that definitely is a big barrier. We can screen and diagnose for different illnesses, but if the medications to treat malaria are not available in the district, then that is definitely one of the bigger challenges.
Yeah, definitely. All right, why don't we move on to the next question? The next question is from Sabrina Hardenberg, and I believe Sabrina is on the line with us. Is that correct? Do you want to ask your question?
I don't remember it verbatim how I wrote it the other day, but just a little background. I did the first baseline health surveys for the Ratsimbazafy National Park project back in the late 80s and early 90s.
Wow.
So I'm curious, given sort of the marginal and seasonality of malnutrition and the family's capacity to grow all the food that their families need and the assortment of villages around Ratsimbazafy National Park, how is COVID-19 challenging or interacting with that already marginal situation that is underlying the malnutrition that one sees in the region, and that your primary healthcare center, which looks sparkling, spanking, brand new practically, to deal with that? And how do you also maybe deal with other programs in the area that shore up the problems with food insecurity, so that malnutrition happens less and then probably would enable people to withstand COVID-19 a little better if they're not malnourished or not having problems with these other infectious diseases like TB or malaria or any number of GI problems.
Yeah, thank you, Sabrina. That's a really important question. So I think I'll turn it over to Laura Cordier, and she can touch on the food security issue.
Great, thank you. It's a very nuanced question and many different components to it. I would say the way COVID is interacting with our malnutrition program, for sure. First of all, in the increased risk that it's creating an opportunity for malnutrition. Though we're in the early days, you know, in Madagascar of confinement, so I don't want to make sweeping statements here, but already the first wave of really strict confinement affected the district of Ifanadiana, the commune of Ranomafana, and people's ability to procure food, first of all, and then also to sell their food. And as you must know, in Ranomafana and in the district of Ifanadiana, there isn't as much food production, for example, as in the high plateaus, especially in terms of diversity. And the issue of malnutrition in our district is one of lack of diversity in food, more than lack of food, which is what you would see, for example, in the south of Madagascar. And so people haven't been able to commute, to sell their greens, the Colliard's greens, which is usually in high season right now. And it's less food to sell, less money, more food insecurity, less access. So it's all interconnected for sure. You know, we're waiting to see and ready to respond hand in hand with local partners that are equally implemented in the community. For example, CVB, Help Simus, that are really also keen on supporting on the food security component. We know that the World Food Program is also ready to start and has a base at our regional, in the region. And so if things get worse, we are already seeing distribution of rice and social support there. So that gives me hope that there isn't going to be a massive, you know, increase in malnutrition, but only time will say, truthfully, with malnutrition. We are recognizing a seasonality. The rainy season is particularly hard for a malnutrition program. We were actually just talking last quarter, there was an increase in loss to follow-up in one of our communes, and because it's been a very rainy season, the water rises, it's hard for community health workers to access. So it's a complex time. And maybe Lova, you can talk about how the COVID, our response has impacted the actual program and the way we manage care. Or you can, comme tu, en français ou en anglais, comme tu veux.
Okay. L'impact.
Ouais, mais juste sur le programme malnutrition spécifiquement.
Ok, donc pour la malnutrition, donc ce qu'on a fait, c'est que au lieu d'avoir les patients, au lieu d'avoir une visite à toutes les semaines, on a fait la visite à toutes les 2 semaines pour limiter leur fréquentation au CSP.
Okay. So for the malnutrition program, as Lova was saying, and I'll add also for the tuberculosis program, which are 2 programs we're supporting where the patients are actually more at risk of COVID, at least in terms of their vulnerability and their immune system. We've reduced the frequency of their visits. And so normally in the best case scenario, a patient is coming once a week for over a period of 6 to 8 weeks to seek care. And in this case, we're reducing to every 2 weeks, unless obviously the patient is in a specific situation, critical state, then the family is being told to come back early. But that's been a shift. I'm sorry, we've gone ahead for a long time. I don't know if there's another nuance that either Alicia or Lara would like to add.
I think we can move on to the next question, but certainly it's a topic we could discuss for hours. So Sabrina, if you have other questions, please send them our way and we'd be happy to respond by email. And also I should note that Pat Wright says hello to you. So I'm going to okay, I'm going to move on to the next question. This is an anonymous question. Actually, Amy, I'll go ahead and read it. So the question, it's twofold. So are you seeing a downturn in vaccinations at the health centers as a result of fears around COVID? And then secondly, are we worried about prenatal care as we worry about COVID? So I'm going to direct that to Lova, but Laura and Lara, if you have anything to add at the end, please do.
Okay.
Ok, je vais répondre en français.
Okay.
Ok, donc pour l'impact de COVID sur la vaccination, oui, il y a une légère diminution de la vaccination, mais c'est passager dû à COVID. Et ce qu'on a fait, c'est que à partir de c'est que avec l'aide de notre équipe communautaire qui font des centres terrain, on fait de la recherche des pertes de vue en vaccination, on fait de la stratégie avancée pour chercher ces enfants-là.
Okay, so I will translate. So we've definitely seen a drop in utilization, but it actually is just at a time where also there's a seasonal drop in utilization with the end of malaria. So we're still trying to we're waiting to see the trend actually before we jump to conclusion, but still the general vaccination coverage, in our opinion, is low. And so as a result, we're working very closely with the community health workers in terms of identifying the children that have not come to their regular vaccine visit, the ones that were considered lost to follow-up, and we're more actively and more than ever actually engaging on what they're calling these targeted advanced strategies. So it's moving the health facility to the community so that health practitioners are able to vaccinate children. And so we're doing more targeted vaccination campaigns where in specific groups of villages that have low vaccination rates. And the second part of the question was around prenatal care. Truthfully, that's part of our mission anyways, is to increase the completion of antenatal care visits. So we're also engaging in mobile ANC, antenatal care visits. But the challenge with COVID actually is an HR problem. So this means bringing health practitioners to the community, and it raises a number of questions, right? We're obviously conscious that we don't want to be promoting the spread of the disease. So we have to be very careful in terms of how what measures that we take when we do these targeted strategies. And also, we are facing a situation where there are not enough health practitioners. And so we've already relocated some of our community team to support in the health facilities, and it's impacting our ability to run the program as we would. And so it's definitely a challenging, and we have to balance, but we're balancing this really in hand with the government. So they asked us last week, we need your teams to go back into the field. We can't compromise community health. Okay, we organize. So we're going day by day. It's a shift in approach there.
Great, thank you both for answering that. I think I'm going to turn the next question to Laura Hall, and this is another question that was submitted anonymously, so I'll read it. The question is, what are you able to do at the health centers? So what kind of service provision can take place at the health center level? And then what fraction of cases have to be referred to the hospital?
Thanks, that's a great question. So the health centers in Madagascar are different than a typical clinic in the United States, meaning that there's some amount of what we would consider more hospital level care. There is primary care and preventive care at the health centers as well, just as you would find in the US. But for example, Laura showed the picture of the delivery table, and so women can give birth at the health centers, not via C-section. That would be someone that would need to be referred to the hospital. But also, if patients may need to stay for a night or two for IV fluids or IV medication, again, that's a service that can be provided at the health center. So they don't necessarily need to go to the hospital for that level of care. And then there's quite a bit of general preventive care, seeing patients for non-communicable diseases, diabetes, high blood pressure, and then treating people for malaria and upper respiratory infections. In terms of what fraction of cases have to be referred to the hospital, from what I understand from the team, about 3 to 5% of cases are being referred to the hospital.
And one thing I would add to that answer is I think that's an area where we have ongoing work to do. I think Pivot has really put a lot of time and effort into a referral service with well-equipped ambulances that have trained paramedics staffing them. And I think that's gone a long way to improve people accessing higher levels of care, whether it's getting from the community to the primary care level or from the primary care /clinic level to the hospital. However, in my own anecdotal experience, whenever I go to a health center, I often find that there are patients who are really sick that need referral to the hospital. And the rate at which I'm referring people when I go and see patients doesn't seem to match with the overall referral rates. So I do think it's an area where there's ongoing work to be done, but leaps and bounds of difference from where things were 5 years ago, which is fantastic. So I'm going to turn to the next question, which is another anonymous question. We have a lot of shy people today. So the question is, how does the community health worker integrate with the health center? Do they refer patients? Do they accompany them to the health center? And this is great because this really ties in with the conversation we had last week and kind of brings it together. So Laura Cordier, can you take that one, please?
Yeah, absolutely. That's a really good question. So as Lara was explaining, the health center really is that middle ground where we can make that connection down and up. So a community health worker should be and does refer patients to the CSB, to the health facility, sorry. When a child under 5 presents a complication or a danger sign, as we call it in the normal protocol, they're referred to the health facility. Now in practice, you know, it's important to remember, I don't know if some of you were able to watch the video yesterday, a referral from the community is not simple. It involves a lot of walking. And if someone is actually critically sick, it involves having to build what they call a tacuna, which is a homemade stretcher, I would say, with anything that they can find to transport the patient to the health facility. And people, it's a community mobilization. People get together, transport the patient. So we're actually working in donating stretchers so that community health sites, especially the ones that are more than 10 kilometers away, have that ready to take, because our research has shown that people spend about 2 to 3 hours to actually make those homemade stretchers, and it's really wasted time in a community referral. Our community health workers also have the phone number of our referral system, and when they have network, which is not often, and they have access to a road, which is also not often, but if they do meet that kind of criteria, they have access to the referral system very easily, and so they call the call center, and a referral is initiated. Moreover, they have the possibility, and they should, if they can, accompany the patient. And that's not just for emergency referrals, it can be for accompaniment of a malnourished child for his or her weekly visit, tuberculosis, non-communicable diseases, etc. So the community health worker has that role. And then the next step would be the counter referral, which is the process by which a health facility is supposed to communicate back to the community health worker what needs to happen, how to best accompany that family through care, and when are follow-up visits. So they have they're that middle ground between the patient and the health center, which makes them so important. And the community health workers get to gather as a group once a month at the health center. And that's where all that strategy happens. So Lova, for example, will go at a community health review, as they're called, and they'll identify who are the lost to follow-ups to vaccination, antenatal care visits. How do we plan together to expand the work of the health facility?
Great, thanks so much. And the next question comes from Robin Herrnstein, who is the chair of Pivot's board. And I should have mentioned earlier in Dr. Laura Hall's introduction that Laura is a Pivot board member in addition to being our former medical director. So she has a dual role with Pivot, and that's part of the reason that she's on this call today. So Robin, I'll turn it over to you to ask your question, and I think this will be the last question for today.
Great, thanks Alicia. I loved seeing the video walking through Ranawafan Health Center because obviously we can't get over there right now to see it in person. So it's great to feel like we're there a little bit virtually. As I saw the check-in with the COVID check for temperature at that outside pavilion, I just realized I don't exactly know specifically what happens. So if somebody walks up there and they have a fever, what is our current protocol? I know we only have 13 tests, so I imagine you're not immediately testing them for COVID. So what are you doing? Where are you putting them? There are those benches of people that look awfully close. Like, I just wanted to hear, have you guys tell me what the latest thinking is. I know it's all kind of designing day to day. So that was my question.
Great question. I think I will turn that over to Lova and Laura to answer together.
Ok, je vais répondre en français. Actuellement, ce qu'on fait, c'est avec le pré-triage, donc s'il y a un cas de fièvre qui se présente, on fait d'abord le test de palu parce que c'est une zone endémique de palu aussi. Et on a des questionnaires pour savoir si c'est un cas suspect de COVID. Actuellement, il n'y a pas encore de salle d'isolement au niveau des centres de santé, des CSP. Les cas suspects seront envoyés au CHRT. Mais actuellement, avec le comité de vigilance du district, on va identifier des salles d'isolement au niveau des CSP au cas où le CHRT sera débordé.
Okay, super. So to translate what Lova shared, so the way it works is every patient, actually, I don't know if you noticed, there's first a hand washing station. So everybody has to wash their hands actually before even entering the pre-triage. Then a health worker will take their temperature. If a patient has fever of more than 38 degrees, the first thing we'll actually do in our setting is do a malaria test, because this is, we're in an endemic area where there's malaria all year round. And we've had a particularly difficult malaria season this year. So it's still running its course, actually longer than ever. And then we'll have specific questions following the WHO protocol to kind of meet the definition criteria for a suspected case. Now, you're right, we only have a few tests. And so right now, because there are so few tests, the test would actually most likely be done in the presence of the district health office team, perhaps in Ifanadiana at the hospital or at the health center. It really depends on how complicated the case is. There isn't currently an isolation area. We are going to be referring patients to the CHRD, and the vigilance committees that are existing in every commune have the responsibility to identify places where they will be isolating suspected cases, because we know there's that gap, right? The protocol in Madagascar is you first do a rapid test, but you need a confirmation by PCR. And that process of doing the PCR, sending it to TANA, that takes time. And so there will be, and we can't do the rapid test if it's not the optimal time to do the rapid test. So it's going to be, we're envisioning a time where patients will have, suspected patients until they're confirmed, will have to be isolated, and we will start the contact tracing. And we have a specific app that's going to help us do that and involve community health workers as well.
Thanks, Laura and Lova, and thank you to all our panelists. I think just to add to that final answer, one thing I would say is that while there are no isolation facilities at the health centers themselves, each commune has identified isolation areas for COVID suspects. So every commune is supposed to have 3 designated isolation rooms for suspected cases. And then there are isolation facilities at the hospital level. So if there was a concern, a patient could be picked up in an ambulance by a paramedic wearing full PPE transferred from there to the hospital isolation facility or the community isolation facility, and then seen by people wearing PPE and using appropriate procedures. So that's also something we could spend a lot of time talking about, but I'm going to wrap it up since we're at the end of the hour. Thank you to everyone who joined us today, all of our panelists. You were wonderful, and thank you to all the guests and the great questions that you sent in. We really appreciate you joining us this week and every week that you're able to. So next week, we'll be continuing this conversation about the importance of maintaining routine services at the hospital level, while also addressing modifications that are being put in place at that level for addressing COVID. And that's really where the bulk of COVID management will actually take place, will be at the hospital level. So that will be an interesting conversation. Thanks so much. And depending on where you are, good morning, good afternoon, or have a good night. Bye all.